So I'm going to talk about just giving you a brief overview of EMG. Everyone is regularly doing EMG, and it's one of the most common modality we use in everyday neuromonitoring. But I thought just pick up this topic and give you a different type of uh, benefit of that. So just uh, the purpose of this presentation is to have an understanding of why we do EMG and know the anatomy and physiology of the muscle monitor, placement of the electrodes, and appropriate selection of the recording parameter, interpretation of the EMG data and documentation, and alerting the surgeon, and understanding the effect of anesthesia. So by definition, EMG is an electrical activity which is recorded from muscles, and it's known as electromyogram. The EMG activity is generated by temporal and spatial summation of the postsynaptic muscle action potential. They are known as MAPs, MAP, and this is a result of an action potential from lower motor neuron reaching the muscle fiber through neuromuscular junction. So electromyography or EMG is the recording and display of bioelectric potential in muscle fibers, motor units, and whole muscles. So those are bioelectric potential which are created in muscle fibers, motor unit, and the whole muscle fiber. EMG has been used in clinic and in IM for many decades to evaluate the functional integrity of the muscles and the nerve innervating those muscles. And IM, uh, in IM, the focus is on the activity of muscle, but the purpose of EMG is to assess the activity of the nerve or nerve root that innervates the muscle. So we are monitoring from the muscle, but indirectly we are checking the integrity of the nerve which is supplying that muscle. Any irritation, primarily from the form of stretch or compression, but also in the form of temperature, heat, vibration, electricity, laser energy, chemicals, cold irrigation can cause axon to fire action potential. So there are so many different factors that can cause EMG, abnormal EMG activity. The greater the magnitude, the greater the amplitude and duration of the irritant, the greater the frequency of action potential fired. The greater the number of axon activated and the greater the time course over which action potential are fired. So depending on the magnitude and duration of the irritation of the nerve, the amplitude uh, will be higher, and depending on the number of the axon being irritated, the time that activity loss will be longer. The irritated axon will have a slower mechanical stimulation. So a chronically irritated axon, any axon which has been irritated chronically due to compression or myelopathy, radiculopathy, will have lower mechanical stimulation. That means if the surgeon touch the nerve, or if you touch the nerve, it will fire very quickly, but it will be more and it will be more susceptible to stretch or compression than the normal axon, and it will have a higher electrical stimulation. So if you stimulate this nerve, it will have higher threshold compared to any normal axon. So once the action potential are initiated in the nerve, they travel to the neuromuscular junction where they cause vesicular release. Vesicles are small um, bubbles and they reach the neuromuscular junction and they open in the neuromuscular junction or in synaptic junction, and the neurotransmitters are released from those vesicles and they act on the postsynaptic uh, contacts or receptors. The action potential or initiation in muscle fiber of the motor, so that will lead to the action potential in the muscle fiber. Motor unit potential or MUPS, MUP, and compound muscle action potential, CMAP, are generated, and this is observed by EMG activity. So when the nerve is irritated, stimulated, the vesicles are released in the synaptic cleft, and they act on the muscle fibers and they cause motor unit potential and compound muscle action potential. The magnitude of EMG activity is determined by the number of the axon, again mentioned earlier, and therefore the motor unit activated and the frequency of the activation. The greater the number of axons activated, the more units are activated and the greater EMG activity. So more axons are fired, more activity will last for a longer time. The higher the frequency of axon firing, the greater the muscle activation and the greater the EMG activity. Therefore, there are rough correlation between EMG activity observed and the amount of irritation of the nerve root. So we can tell by looking at the EMG activity, if it is very high amplitude, short duration, that means the irritation is much, or the irritant is much more higher magnitude. And
where the causes recorded dynamic information with the muscle having the motor unit subsequent action potential initiated.
can you meet the, sorry.
Subsequently, action potential is initiated in the muscle fibers of the motor unit potential and component is generated in this. The magnitude and the motor units activate the frequency of therapy. Activated the more motor units activate, the greater the intensity of the frequency.
Hello.
The more activation, the greater the activity. Therefore, there is a rough conversion.
Can you mute your mics, microphone? Okay, I'm good. Sorry, thank you. So there's a rough correlation between EMG activity observed and the amount of irritation. So looking at the amplitude of the EMG activity, we can tell there's a much higher irritation, and if it's a longer period of time, that means more axons are irritated or activated. EMG will appear as either as a single spike. You can see a spikes, a single spike, biphasic spike, or triphasic spike. We can see a burst, which is multiple spikes together, or repeated spikes or burst, and they're either, if they're repeated spikes, it's called train activity. It's repeated spikes and burst together, neurotonic discharge. All these events occurs randomly in the time and therefore appears at random times throughout the recorded. So they are going to, during the course of surgery, they will appear at a different time. The purpose of EMG is to provide real-time feedback of motor nerves and nerve roots to the surgeon. It detects the mechanical irritation by correlating corrective action. So if you pick up the mechanical irritation, we can inform the surgeon and the surgeon can do corrective action immediately. And the severity of duration of irritation will give the feedback, so the corrective action can be taken. At the same time, documentation of the nerve irritation, EMG activity gives us information, and the nerve is being irritated, and they can be documented. And if we can use trigger EMG, which is stimulation, is used to identify the nerves or pedicle screw integrity. So the trigger EMG is used to find the nerve, to track the nerve, or to check the integrity of the nerve at the end of the surgery. So just brief anatomy and physiology, the record activity or muscles. So EMG record activity or muscle which was generated by nerve root. For example, C5 surgery, we need to monitor 2 levels above and 2 levels below. So the myo times, I'm going to go on later and show you the diagram. So there's no fix, it's not a fixed one root supplying one muscle, and there's always overlap. If the muscle for deltoid is primarily C5, and if deltoid is supplied by C3 and C4, that is known as prefix. Prefix means it's supplied by the earlier muscles. And if you stimulate a C6 or C7 and you get a response from deltoid, that's not a postfix. So you have sometimes you have prefix and postfix in different patients. So in order to make sure that we are covering all the nerves, so we always monitor 2 level above, and we do recording until 2 levels below the surgery. So if it is C5 corpectomy, we monitor C3 to C5. We will monitor trapezius, deltoid, biceps, and brachioradialis muscle. And any C5 irritation will create depolarization by having axon send signal to the terminal and causing muscle fibers activation. This is MUP or MUPS. So a single nerve root innervates several muscles, and each muscle is innervated by the nerve roots. So one nerve can innervate multiple muscles, and one muscle can be innervated by multiple roots. There are two types of neurons in the motor pathway. One is upper motor neuron, the second is lower motor neuron. The upper motor neurons start from the pyramidal cells in the motor cortex, primary and precentral, and they travel down and they make a synapse with the lower motor neurons in the spinal cord. The lower motor neurons start from the anterior horn cells uh, and it connects the upper motor neurons to the neuromuscular junction. So there are two neurons in the motor pathway, primarily upper and lower motor neurons. And when we are doing motor evoked potential or we are monitoring the EMG, so it's important to remember that uh, we are the only 95% of the fibers they innervates those. We can activate only fibers, and 95% fiber we cannot activate because we are activating 95% of fibers. That means when we stimulate MEP or do motor stimulate the brain or direct cortical stimulation, we can only activate 5% uh, the fiber directly, and 95% fibers in the lower motor neurons are activated through the interneurons in the spinal cord. So that's why the lower uh, if for a motor evoked potential, the anesthesia affects uh, mostly in the spinal cord by blocking those interneurons. So motor unit action potential or MUAPs, they're combined action potential of many muscle fibers attached to one axon. Uh, must be able to see multiple unit action potential to monitor responders EMG. A motor unit is one motor axon and all. So every motor unit has four parts. It anterior horn cells in the spinal cord, lower motor neuron, neuromuscular junction, and muscle fibers. So those four items they combinedly known as motor unit. So if when you connect the patient and you see the EMG activity, so it's very important to know if there's a patient has a baseline EMG abnormality. Most of the time, high percentage of people they start monitoring and they don't even look at the baseline EMG abnormality. And that's baseline EMG abnormality gives us information if the patient has pre-existing condition or not. The most common one is fibrillation. And if you look at this picture, the A is fibrillation, and it is characterized by a positive sharp waves, single asterisks, and these two double asterisks. So these are all positives, and these are called fibrillation. And this is typically due to denervated hand muscles. And if the nerve is cut or damaged, it takes 7 to 10 days, and after 7 to 10 days, the muscle become hypersensitive and it starts doing fibrillation. The second picture is neuromyotonic discharges. They can be single or double or triple or uh, multi multipolar. So there are single one, two, three, four peaks, multiple motor units firing at the same time, and burst of discharges are irregular in frequency, and the intra-burst frequency of discharge is up to 200 hertz. So they can be a single firing, two unit firing, three unit firing, four, but they are random. The frequency between them is irregular, and it can be as fast as 200 hertz. Okay, so this is the nerve root chart, and I'm sorry, I think I'm in the office with high-speed internet, but for some reason it is still not connecting. So this is the nerve root chart, and sorry for the interruption. So I don't know what happened. There was some sound issues and something, but anyway, so I'll go back to a few charts and pictures and. So again, going to go quickly over the train activity. So the abnormal spontaneous EMG activity we can see is fibrillations. Fibrillations is the first one on the top. They're positive sharp waves, and they are present due to damaged nerve, and is typically caused by the patient has the nerve is damaged or cut. Um, it after 7 to 10 days, after 5 days, it takes 5 days, 3 to 5 days to cause Valerian degeneration, and after 7 to 10 days, the muscle become very hypersensitive and it keep firing continuously. So fibrillation is the first trace which is caused by the cut nerve or damaged nerve, and you can see that the positive spike waves on the baseline EMG when you start the baseline EMG. The second one is neuromyotonic discharges. Neuromyotonic discharges is the B one, and it can have a single, double, or triple, or multiple motor unit firing at the same time, and they have intermittent interburst frequency, and at up to frequency of 200 hertz. The third one is fasciculation. The fasciculation are single discharges and are irregular and occur on background in the EMG. So you can see the single spikes; those are called fasciculation. The fourth one is myotonic discharges. Myotonic discharges is number D, the last one, and it has characteristics of waxing and waning. So you can see the frequency goes higher and low, and the amplitude get bigger and less. Train activity, there are three types of main train activities, A train, B train, and C train. The A train on the left side is a sinusoidal sudden onset train. It ranges from 100 to 200 microvolt, and it can be from 60 hertz to 200 hertz in frequency. It can be a continuous A train or intermittent train or burst train. The second one is B train. B train can be a single spike burst uh, or a burst spike. So B train could be a single spike or a burst spike. The last one is the C train, which is continuous, irregular, and composed of numerous overlapping components. It has multiple amplitude train activity with the multiple unit firing at the same time. So you will not see a train the amplitude uniform. It will be multiple in different amplitudes. So the use of the motor EMG is to monitoring the nerve root compromise or cranial nerve monitoring for nerve root for pedicle screw testing, making sure that the screw is not breach or decompression of the spinal stenosis, interspinal cord tumors, quadricona tumors, correction of scoliosis, and by overcorrection, you can do spontaneous trigger EMG, radiculopathy, spondylosis, other type of surgeries. So when you're preparing the skin, you have to make sure we are doing alcohol prep and the skin is clean before putting. Even the needles are not hollow. They're not hollow needles, but still it's a more sterile application to apply alcohol prep over the skin quickly and then start putting the electrode. The needles are placed as an active and reference, or they can be used as a bipolar. They're placed subdermally over the muscles, and they should be at least 3 centimeters apart. And the muscle groups present whichever muscle group we are recording, we should be recording at least two roots above and 2 roots below. So it's always good to have a nerve root innervation chart on your desktop. So whenever you're doing a different type of surgery, so you have the chart and you can monitor that. You can download. I send email to everyone, but if you want, I can resend to you. But this a cheat sheet, a chart, good chart to keep on your desktop. In short, for the upper extremity, the typical muscle monitor are trapezius or sternocleidomastoid is better option because it's a shorter muscle and you can have a better responses. Trapezius is a very big muscle and we have very high risk of not picking up a response. Deltoid for axillary nerve for C5, C6 root, bicep for musculocutaneous, tricep for radial nerve, extensor digitorum for radial nerve C7, C, and abductor pollicis brevis and abductor digitorum. Those are the typical also flexor carpi ulnaris, flexor digitorum, dorsal intrasoi, lumbricals. Those are other muscles we can monitor in the upper extremity. For lower extremity, many times techs are monitoring iliopsoas muscle, but iliopsoas muscle is a muscle which is inside the iliac bone and it's very, very deep. So if you're putting any 20 millimeter long needle, you cannot reach iliopsoas muscle. You have to use a longer 37 or 50 millimeter long muscle. Adductors, Magnus for quadriceps, for femoral, tibialis anterior, for peroneal, extensor hallucis longus, gastrocnemius, abductor hallucis, anal sphincter. Those are the most common muscles we do for low. For spontaneous EMG, just we do left and right side, and we have multiple units. You can see we have this a train activity. In this picture, you can have train activity. Um, with tibialis anterior on left side, all the activity is single spike B train, and on the left foot it is a C train. So if the patient start waking up, if you're doing spontaneous EMG, you can look at the EMG activity and you can tell the patient is waking up just because every muscle will be contracting and it will have very large amplitude responses and with have sinusoidal waveform and with a boost. So in summary, again, spontaneous EMG are recorded from the distal muscles and they're recorded as associated with the nerve and nerve root mechanical insult. EMG is used when spinal root or rootlet nerves are at risk. Passive recording for muscle activity by free run EMG and spontaneous EMG by using subdermal needle electrode, and active triggering EMG is done by CMAPs or compound muscle action potential or triggered EMG. We can use monopolar stimulation, we can use bipolar stimulation, and we can use a tripolar stimulation. So the application of just going to give you the uses of the EMG. So that was my main purpose to talk about different type of surgery. Number one, everyone knows about the pedicle screw stimulation. So the use of spontaneous EMG and triggered EMG for the pedicle screw stimulation. So every time there's a breach, especially medial breach or inferior breach, there's a good probability we can pick up by triggered EMG. It is important to know and communicate with the surgeon also that spontaneous EMG is not going to pick up every type of damage or irritation to the nerve. So by looking at spontaneous EMG, we cannot tell the nerve is intact. In order to confirm the integrity of nerve, you have to do stimulation. Either you're a peripheral nerve or you're doing cranial nerve, you have to stimulate the nerve. So when you're doing pedicle screw stimulation, so if the patient has osteoporosis, very old female patients, all the screws will be low amplitude, but they may not be breaching because the bone is porous, so the thresholds are very, very low. For there's a micro breach. So micro breach is a very small breach which opens only when you put the screw. If you take out the screw, the breach will be gone. So if you stimulate the hole or a probe, the threshold will be very, very high, will be higher. But when you put the screw back, the threshold will be low. That's a typical characteristic of patient as having a micro breach. There are also other new so different type of screws, and you have to make sure we are they are polyaxial screws, and they don't have a full contact with the screw body. So you have to make sure you stimulate through the screw and through the head and touching the screw. So the surgeon is not touching the head. Also make sure you have this. It's plugged into the cathode. It's not plugged to anode. There's no CSF or blood or any any type of fluid in the exposed area before you stimulate. The return current, the returns anode should always be plugged in the midline and above the screws. So the recommendation is putting above and in midline between two scapula or something if you're doing a lumbar screw, because if you put on one side, the current will shunt on one side and you'll have a more artifact on one side, stimulation artifact, and less on the other side. Also, if you put the electrode on one side, the current will shunt there. So it's better to put above, not, don't put between the stimulation and the recording electrode. So just showing trigger EMG response. So we have trigger EMG response from the upper left and right, and spontaneous EMG on the left side. So when you're doing triggered EMG, you can also see a spontaneous EMG on the bottom. Motor mapping. So triggered EMG beside pedicle screw can be used for motor mapping. So this motor mapping with picture on the left side is spontaneous EMG, right side is triggered EMG response with the stimulation of the direct brain at a 50 hertz stimulation, which is a Penfield method of stimulating brain for motor cortex mapping. And you look on the right side, we have stimulation at 4.3 milliampere direct cortical and recording spontaneous fatigue EMG. And at the bottom is electrocardiography. And on the right side, you can see the microscope is connected to the computer, and the surgeon is holding the bipolar electrode and stimulating the trigger EMG. If you look at the DECS responses, which is stand for direct electrical cortical stimulation, each response is 20 millisecond apart because every box is 10 millisecond. So every response is 20 millisecond apart. So, and that's because it's 50 hertz stimulation, and 50 hertz means ISI of 20 hertz. So if you stimulate with 50 hertz, you get a responses, and the time between each response will be 50 hertz, 20 millisecond. Another application of the EMG is dorsal root rhizotomy. So dorsal root rhizotomy is done for the treatment of spastic paralysis. So the kids who have spastic paralysis, so we identify the ventral roots and dorsal root, and each dorsal root is split, is wrapped into the wrapped, and then we open every single wrap, and each split the root into rootlets and use a hook electrode and stimulate with the 50 hertz stimulation. And on EMG on the left side, you can see, look for the abnormal responses, which can be graded from 0, 1, 2, 3, 4. And if you stimulate L2 roots, rootlet, you should get response only from quadriceps muscle. But in this case, we are stimulating one rootlets. It's not even full root, and every single muscle on each side is firing for this patient. So these are the first interpreted EMG responses. When you are stimulating for 1 second duration, the response either should be decremental, so the artifact should be either get smaller or stay on the same size, which is called squared. So decremental EMG or squared EMG is a normal response, but in patient with cerebral palsy, they have abnormal connection, and we can see incremental. The signal get bigger and bigger, or it will be clonic, up and down, or it will be multiphasic. You have positive and negative, or just sustained train activity. So those are the 4 different type of abnormal responses. EMG, we look for the rhizotomy, and we grade them into 0, 1, 2, 3, 4. So you look for the abnormal response and grade into 0, 2, 4, 5, 4. 0 means no response, 1 means response from the same muscle, 2 means response from same muscle and next muscle, 3 means response from same muscle and the most distal muscle in the leg on the same side, and 4 means you're getting response from all other muscle in the body. So for rhizotomy, the most important part before you start splitting the dorsal root is to find the dorsal root. And we stimulate the ventral root and dorsal root. So the time between the two is very, very less. It's about 1 millisecond. The threshold is there's a difference, but it's not too much. The motor units are about 0.05 to 0.2 milliampere, and dorsal are 0.5 to 1 milliampere. Patient with Lipomyelomeningocele or lipoma or myelomeningocele or tethered cord, the most important modality to monitor is the trigger EMG or EMG. So the tumor is a fat tumor, and the surgeon has to identify the phylum in the fat tumor. It's very difficult without the trigger EMG. So in this picture, on the right side, we can see the stack of the trigger EMG, and then in the middle we have trainer 4. On the left side is spontaneous EMG, where we can see the nerve is firing continuously due to the irritation. The irritation of the nerve root is calling, and if you are doing trigger EMG during that irritation, it's very hard to identify the response. The response will not be at this. So if you if you see a response and the response is not at the same latency every time, that means it's moving. That means it's an artifact. It's not a real response. So in this picture in the middle, you can see the trigger EMG responses. They are up on the 2 places. So that's not a trigger EMG response. It is a response to the stimulation artifact. Bulbocavernosus reflex is another EMG response. It's performed. We do that routinely for tethered cord cases or cases where quad icona tumor, where the quad icona or the lower nerves are at risk. You stimulate in the genital areas in the female and male by anode cathode and record from anal sphincter on the left side and the right side. So if the bulbocavernosus reflex is done with the SSOP, it has higher predicted value along with the trigger EMG and MEP. H-reflex is another EMG response. H-reflex is, again, if done with SSOP, if done alone, is not of that value. But if you have H-reflex, loss of H-reflex with loss of SSOP, that means patient will have a proprioceptive deficit postoperatively. So if patient have only change in SSOP, is not as predictive as having changes in SOP and H-reflex. The H-reflex is done. The first response we'll see is a M wave, which is a muscle response. The second one, the red arrow on the left side and the blue arrow on the right side, those are small H-reflexes. I have a better picture, but so those are responses, and this is stimulating the popliteal fossa, needle electrode in the popliteal fossa, and getting response from gastrocnemius. So if we look at this response is occurring about 40 milliseconds. The first response is about 8 to 9 milliseconds, which is a muscle M wave, and the second, so the signal go to the spinal cord, it make a reflex and come back and activate, and that's why it's delayed. And if there's any damage to the spinal cord or a shock to the spinal cord, it's only S1, so it covers only S1 route. So EMG and MEP can be recorded from the urethral electrode. So we have a urethral electrode which is placed in the bladder as a catheter, and this picture is a motor evoked potential response, and this one, the second one, is the trigger EMG response. So trigger EMG responses on the left side is abductor foot muscles. The middle one is anal sphincter on the right side, and the third one on the right side is external urinary sphincter. So trigger EMG, we can get a very good trigger EMG responses from the urinary sphincter also. And the benefit of that is because the pudendal nerve supplies anal sphincter and urethral sphincter, the fibers going to anal sphincters are different than the urinary sphincter. So if you have a response from an anal sphincter but not from urinary sphincter, so we cannot tell those are intact, and patient may wake up with a urinary incontinence. And surgeries at the quad icona have a very high risk of having postoperative urinary incontinence. So when we're doing subdermal needles, depending on the length of the needle, so if you have, we typically use 13 millimeter long needles. But now we have longer needles, which we use them, which are 18 millimeter, 25 millimeter, 37 millimeter, and 50 millimeter. The longest one is 50 millimeter. The needles are insulated except for the tip. So if the patient is obese and the BMI is very, very high, and if you put a subdermal needle, you will be very far from the muscle. So having a longer needle, you have more possibility of reaching the muscle. This is from one of the patients. So if you look at the picture, we have I have this 13 millimeter, then 18 millimeter, 25 millimeter, 37 green, and blue is 50 millimeter. Those are the spawns. So for the electrode 18 to 50 millimeter long needle, they are hook 90-degree hook, and they also come in 37, 36, 30-degree hook. They are very well secured. So even sometimes you don't even need to, most of the time you don't even need to put anything and they will not come out. But if you look at 13 millimeter needle, this is protruding out and it's ready to come out. So you have to make sure you are securing these muscles. So same another patient, same using of the 37 millimeter, 25 millimeter, 18 millimeter, and regular 13 millimeter single needles. And on the right side, I took this X-ray of this patient post-operatively, and you can see the 37 millimeter needles are reaching at a much lower and more distal part compared to the other 4 needle. The subdermal needle was very superficial. So EMG recording for motor recording from comparing from 13 millimeter, 18, 25, and 37 millimeter in this picture. On the bottom, you have free running EMG, and on the top is a triggered EMG. So in this specific this patient, we have the signal size for motor evoked potential was about 700 microvolt in 37 millimeter and 153 microvolt 25 and almost zero in 18 and 13 millimeter. So if you look at the triggered EMG, spontaneous EMG, you can also see artifact in 37 millimeter on spontaneous, but not in other. So the spontaneous EMG captured the motor response only in 37 millimeters. So if we had used only 13 millimeter or even 18 millimeter, we're unable to pick up a response in this patient. The second thing is the subdermal needle, the needles which are subdermals, the current spread over your surface of the skin, and that's called DC current. And that DC current gives you a very high stimulation artifact. And you can see the stimulation artifact is much higher than 13 millimeter compared to the other one, which are more insulated and have less stimulation artifact. Cranial nerve EMG. So application of cranial EMG, we can monitor cranial nerve 3. We can put electrode in medial rectus. You can monitor superior oblique for cranial nerve 4. You can monitor lateral rectus for cranial nerve 6. You can also monitor inferior rectus for cranial nerve number 3. So we can use those paired electrodes and put the electrode next to the eyeball. You have to make sure you have experience in that and don't try without having some experience done with a senior neurophysiologist. So you have to push the eyeball on the side before you putting the electrode, and you're putting the electrode away from for the eyeball, so it doesn't penetrate the eyeball. This is EMG train activity from one of our cases. You can see they are very sensitive and picking up manipulation of the cranial nerve 3 in this picture, but no. So 4 and 6, they are very close, but they are not picking up the response because they're very sensitive. Specific. The other cranial nerves, so you can record from cranial nerve 5, 6, 7, 8, 5, 6, 7, 9, 10, 11, 12. All the cranial nerves except for 1, 2, and 8, we can do monitoring. So the latencies are different. The medial rectus is about 4 milliseconds. Superior oblique is about 7 milliseconds. Facial nerve is about 7 milliseconds also. Lateral rectus is about 4 milliseconds. Facial nerve have 5 branches: temporal, zygomatic, buccal, mandibular. We can monitor all. You can put the electrode in frontalis for temporal branch, oculi for zygomatic, oris for buccal, mentalis for mandibular, and cervical for platysma. Platysma muscle for cervical branch, and we'll monitor all the branches. This is a fourth ventricle tumor. So fourth ventricle to EMG is again uh, one of the very important modality for mapping of the fourth ventricle. If you look at the picture on the right side, the fourth ventricle is has a nuclei of multiple all a lot of cranial nerves 3, 5, 6, 7, 10, 11, 12. So there is embedded in the floor of the fourth ventricle. So this is the fourth ventricle, the roof, and this is the floor. So the typical surgeon comes from the cerebellum side, and they make incision and they try to take out the tumor. In this picture and the video connected to the microscope, you can see there's a big tumor on the floor, and the surgeon is stimulating with the monopolar stimulator and trying to find the nuclei of the nerve. So this one is coming from the orifice or facial nerve nucleus, right where he's stimulating. So if you make incision without mapping or doing EMG, trigger EMG, he will damage those nerves and or nuclei actually. So the nerves are not damaged, but the nuclei are damaged. So nerve will not be able to act. For peripheral nerve surgeries, we do monopolar, bipolar, tripolar stimulation. The monopolar can be sharp or blunt, or ball tip for pedicle screw. Bipolar can be a hook bipolar or side by side or concentric bipolar. And tripolar are the most important for peripheral nerve monitoring. The two sides are anodes and the middle one is plugged into cathode. So if you're doing brachial plexus trunk lesions, we stimulate the roots. Patient with the brachial plexus trunk lesions, we stimulate the roots and record selective from the trunks, divisions, or cord. And depending on which nerve is intact, the surgeon do the nerve grafting. So this is one of the surgery. And again, we can see the surgeon is looking at the microscope and he's stimulating on this hand. You can see you have the probe on the left side coming from the bottom. Probe, he's stimulating the branch, and we're getting response from flexor carpi. Ulnaris is very, very small. It's mostly abductor pollicis brevis, but no response from the other muscles. And this nerve was fascicles were created, and one fascicle was grafted with the musculocutaneous nerve on deltoid. So patient has deltoid, was not able to use biceps and deltoid. So this was a nerve grafting again, bringing the two branches, the flexor carpi, ulnar nerve, branch of ulnar nerve, and grafting with the branch of the musculocutaneous nerve for the deltoid. Cranial nerve EMG. So you can see cranial nerve 3 first from recorded from medial rectus and inferior rectus for first two channel, and then superior oblique for cranial 4, and masseter for cranial number 5, and for lateral rectus cranial number 6. So those are spontaneous EMG from these muscles. And again, lower cranial for CPA tumor, so we can do masseter cranial 5 for masseter, oris and oculi for facial nerve, soft palate for ninth cranial nerve, false focal cord for 10th, and trapezius for 11, and tongue for 12 cranial nerve. For the trapezius, we always look, especially on the left side and sometimes right side too, you look at the EKG artifact. So cranial nerve EMG again, it's always good to have a stack looking at the same time. So when you're monitoring trigger EMG, you should have spontaneous trigger EMG and stack at the same time, because it will store that and you can look back very quickly. Another application of the EMG is using the urethral electrode. Again, from urethral electrode, we already mentioned that. So if you do that, spontaneous EMG, looking at EMG is quiet running. There's no baseline, so it's always good to make sure the baseline does not have any fasciculation, fibrillation, or neuromyotonic discharges, because the patient has a fasciculation and fibrillation in the baseline. That means if you're doing a pedicle screw stimulation or a direct nerve stimulation, the threshold will be higher. So if you have a threshold of 9 or 10 milliampere for a pedicle screw, that may be a bad screw, maybe a breech screw, because patient already have a breach in that area. So EMG train activity, this is one of the videos. So if you look at EMG train activity, patient is the nerves roots are irritated. Patient is look like patient is ready to wake up. So you have A train, B train, C train, all trains, and burst activity going at the same time. But it's very important to get used to the different type of train activity and see, and also fasciculation and fibrillation, and make sure you get that identification for the cases. So if you look at the raw unprocessed EMG, this is a picture from gastrocnemius with with a person volunteer. He's pedaling a bicycle 80 cycles per minute, and you can see the contraction and spontaneous EMG from the gastrocnemius muscle. So that's the end of my presentation. So that was the end of the review of just the different application of the EMG and something we can use and apply. So looking at different type of surgery, so you can get, but again, trigger EMG and spontaneous EMG both are very, very important and should be done for identification of the nerve and for the integrity of the nerve. Thank you. And if you have any question, you can send me email, you can call me.